Good morning. Many thanks for the kind invitation of SGH for me to speak to you about this interesting topic, somewhat futuristic, but hopefully will be coming soon. My topic is on technologies in GI conditions and especially pertaining to endoscopy. So I'd like to actually take you through a few issues which I think are important as far as how adoption of endoscopy technologies are concerned. So let me perhaps, can we just switch to my slides, please? Let me perhaps take you through a few important observations we have encountered in our battle against GI cancers. If you look at these slides, this is the data on surviving cancer in US, and quite recent data. You can see that while most cancers are actually surviving rather well because of all the early detection methods, the GI cancers still are not doing particularly well. So one actually has to ask a very important question: why are we not doing as well in terms of how we manage GI conditions? So this is where the top ones are actually, to me, there are cancers which are easily detected. They are either external or we have very good methods to screen these cancers. Whereas GI cancers are more internal. So this is where symptoms become important and lack of symptoms becomes crucial. So we cannot rely anymore on symptoms. We have to have proactive means of detecting these cancers early. So currently, unfortunately, while we know that the future of GI cancer is early detection, so early treatment, but the screening of GI cancers relies upon something which we don't have. That brings me to the important issue. How do we actually detect cancers? We use our eyes. Because we cannot see these cancers in the GI tract, what do? We put a scope in. The scopes are our pair of eyes. And then after that, because we cannot take the tissue sample, we take something called biopsy and put it under the microscope. So well and good. So far, that's the kind of thinking behind how we screen cancers. If I tell you that this method doesn't actually answer an important question, which is what we call real-time diagnosis, because we cannot actually look at certain things and make very good diagnosis, and then we cannot, because we cannot make very good diagnosis, we cannot make decisions on the spot. So this is where I think the current thinking behind is there are many strategies which are now possible if we can do real-time diagnosis. So now, coming back to technologies, many technologies are coming to the fore to try to answer these questions. Can we actually provide real-time diagnosis? Certainly, I think the scope companies, accessory companies have come up with various modalities such as narrowband imaging, confocal endomicroscopy to try to answer this question. So if you look at narrowband imaging, this is white light endoscopy. We see some lesion at the OG junction. Looks suspicious. And then we switch on to MBI. To the trained eyes, very easy. They say this is adrenal cancer. But if I ask you, how confident are you of this diagnosis? Real time. Unfortunately, even in US, when they perform a study among community gastroenterologists, they find that only 25% are able to assess the polyps with 90% accuracy. And this is a cutoff ASGE set for us to use optical diagnosis in place of a tissue biopsy. So this is where the issue is. While all the companies are claiming you can do this fantastic thing, that fantastic thing, but in real life, the situation is different. Then confocal endomicroscopy, we know all this. We know that if you shine on this thing, you can actually see all this. Very fantastic. 1,000 times magnification, and then this thing as well, and then this thing. So what it is, obviously, we know this is intestinal metaplasia, and this is high-grade dysplasia, and this is adrenal cancer. So I can challenge you. How many of you are able to actually make the diagnosis confidently? So this is where the issue is, the training effect. When we study our own gastroenterologists in NUH Singapore, we find the same thing. Experienced people, 95%. Trained gastroenterologists, but not experienced on focus, 60%. And this is not good enough. So what I'm trying to get at, the solution, I think current solution is always say that complexity is good. We go on to complexity. Whenever we want to do things, we go into more NBI, another something, high resolution, high magnification. That's a problem. But the thing is, if you ask yourself, what is the issue? The issue is about making a diagnosis. It's not about technology. Similar to when you go across the immigration in the airport, like for instance in Saudi airport. It's not about trying to see how beautiful your face is. It's about identification. So if you swap face recognition with just a fingerprint, so much easier. So I have to put my fingerprints in the airport. Is to actually see whether I'm the real person or not. So the same thing. It's not about image. It is about diagnosis. Okay, if I can't get this. Oh, sorry. Somehow the computer didn't. It's about diagnosis. That's where we came across this technology called Raman spectroscopy. Essentially, it's a technology which enables us to vibrate the molecules. In doing so, we can actually produce a spectroscopy, similar to drug assay. When we look at certain drugs, it gives a spectrum. So the spectrum is only 6 peaks. 4 peaks is good enough. So from the configuration amplitude, you're able to make a real-time diagnosis. So I think with that, we managed to come up with this thing. I won't bore you with the technicality. Suffice to say that it's just a simple probe which transport the laser beam onto the tissue, and then through the tissue, a vibration, we are able to generate a Raman spectrum, which then goes back through the same probe, goes back all the way to the spectrograph, and then after that is interpreted by software. Nowadays we can do this because of powerful software, which then makes the instant, real-time, less than 1 second molecular diagnosis. It just happens that tissue with any change will give a different pick, and the computer can actually pick it up. And then it's so much simpler than the right-hand side where the pathologists have to read and still not sure whether they are reading the correct thing. So I think the molecules actually is our lowest denominator of human. If you say that this is this molecule, then it must be this molecule. It doesn't matter how it looks like. So that's the thing about certain technology. It's similar to computer. Why is computer so fast compared with all alphabets? Because only 2 things it needs to know, 0 and 1. So I think simplicity is a way forward in terms of quantum physics and whatever it is. So let me show you the video on how we utilize this Raman spectroscopy in our clinical setting. So we have done more than 1,000 patients, and so far, I think we have actually built a system which is able to do that. Sorry, just because this is not loaded. I'll just wait for a while. So essentially, it's a system where we put a probe in, and then we can actually examine. Let me just go straight to the original one. It's probably easier. I'll just go straight to this thing, perhaps. Okay, so I think we do our usual, and that's our Raman probe. Once we put it in, and that's just the screen, which is in a system, which I'll show you later on, because we just missed this thing. So if you see this particular lesion, well, this is just intestinal metaplasia. The screen comes out, so low risk. Straight away, it's because the computer sends a signal, and then this is a cancer. So once you touch it, it's supposed to be a sound, you get this signal, which is called high risk. If you don't believe in that, you take it and then to the normal tissue. So you touch a normal tissue, that's just a normal probe. You touch a normal tissue, and then you get the normal tissue. So in this way, I think you're able to correlate with pathology. And sorry, this is our system on the left-hand side. So I think with this technology, hopefully we are now actually have a company to further develop this. How do I actually come up back to the screen? I'm lost here. I just come off. Oh yeah, also, sorry, it's here. Okay, so we tested, as I mentioned before, now is actually approaching 1,000 patients with esophageal, gastric, and colon lesions, and we obtained more than 90% diagnostic accuracy, more than 40 to 50 publications on this subject. So moving on, I think I touched upon the issue of detection, early detection, using something which is real-time, which is objective, which is operator independent. That's the kind of ideal in the world. The next issue I'd like to actually deal with, again on cancer, is, so if you say that you do massive screening process, and the endpoint, why are we doing GI cancer screening? The endpoint is to find early lesions. And you know that if you see early lesions, you have to remove these lesions. Colon is easy, polypectomy. Whilst GI cancer, upper GI cancer is tough because the lesions are not polypoid. So that's where Japanese came up with what we call the different ways, doing ESD, EMRs, and so forth. So well and good. That's actually good for the A-listers, very experienced warriors who can actually do things using their hands. But you know that in scopes, what is the challenge in doing scopes? It's actually, you need the left, and then you need the right, and you only have one arm, and to try to manipulate things. So I think people are stuck with this thing. They like to be heroes. They do everything possible using one arm. They train themselves using one arm. So I think then you got a problem, physical challenge. Because why? Because surgeons actually use two arms. So they are able to do a lot more than you. Unless you really become very good. That's one way. So what is the solution then? Is to actually use one means to turn one arm into two arms, which is what I call the chopsticks. Chopsticks is actually turning one arm into two arms. And how do you do that? You try to use something which is called robots to turn one arm into two arms. I'm going to show you, this is our invention, similar to the Raman spectroscopy. We are trying to move into using technologies to enable to try to minimize limitations, physical limitations of humans. So the robot is something like this. We call this the Singapore crab, chili crab, the master and slave transluminal endoscopic robot. In short, it's called the MASTER, M-A-S-T-E-R. So essentially, it's a two arms, a pair of arms, robotic arms, going through the scope biopsy channels. And in doing so, whatever you do from outside, okay, on the master console, is transmitted to the slave robotic arms. So I think we actually, because of this initial concept, we further developed it, and we managed to perform, using this robotic endoscope, world's first robotic gastric ESD in 2011. Close to 5 years ago, on 5 patients with early gastric cancer. We did the trial in both India as well as Hong Kong. So this is one of the experiments, trials, which was conducted live, in the live case demo in Prince of Wales in December of 2011. Myself there and Philip Chiu, and we removed these lesions from a patient with gastric dysplasia in the antrum. So you can see that essentially this pairs of robotic arms allow us to resect it using the conventional surgical technique of grabbing the tissue on one side, stabilizing it, exposing the underlying tissue, and then dissecting gradually away. So eventually we publish this series of patients in clinical gastro and hepatology. So moving on, then you say, so what? Again, the so what? So what is so good about robotic compared with humans? Of course, if you train yourself hard enough, you're always able to do certain things. But for the A-listers, the challenge is the B-listers. So I believe the main values of robotic endoscope in ESD is firstly, shorten the learning curve. Because a lot of people in the West still are struggling to try to do ESD. So I think we did an experiment using our prototype robotic endoscope, but for the interest of time, I won't go through everything. And essentially, this is published in the Endo International Open to say that I think even for compare with experience and non-experience, obviously experience the rates, the blue ones takes a shorter time to do it using the robotic endoscope. But even for the non-endoscopies, they were able to actually do the ESD with no prior training, zero training, on the spot. Okay, it's like playing the video game. So the master enable platform allow novice without any endoscopic experience to complete the ESD procedure. So moving on, the second value, one is shorten the learning curve so that at least people the B-listers can actually do ESD. Second thing, I think the biggest limitation of propagating a technology is about addressing complications. I think the two most feared complications of ESD is bleeding on the left-hand side and perforation on the right-hand side. This is where we believe that if we have something which is similar to surgery, then there's a chance that you're not so worried about complications, such as repairing perforation the surgical way using this thing, tying the knot and so forth. So this is still early. This is just a kind of benchtop experiment. But suffice to say that what we believe that the future of, sorry, the spelling mistake. We believe that the future of surgery is really, especially in terms of full thickness, in terms of nodes, is really about a platform which allows both the endoscopies and the surgeons to work together. So it is not a competition. It's just about the most ideal way of addressing issues in future. It's not about, it's actually the most minimally invasive things. So I'm going to actually share with you again another video perhaps to kind of demonstrate this point. Oh, how do I actually go back? Can somebody give me a hand on the videos? Okay, it's here. I just maybe share with you this video. It's okay.
Did you get it?
Yeah, I think it's okay. So this is a video. This is one of the later models. So the master console is on the left-hand side. Okay? Yeah, just a master console. So it's a very simple thing. We developed in Singapore. So you can just sit down like the Da Vinci and sit down and then operate upon it. And then you use the same scope, which I'm not allowed to show you because it's still proprietary. The scope, which is developed by one of the endoscopy companies. So it allows you to do the thing. There are 3 channels of the scope, very thin. It can be just inserted. So one of the channels, you do the usual thing, put the injection and so forth. And then after that, 2 other channels, which are bigger, allows the robotic arms to go in. Okay, so you do the usual submucosal injection, elevation, then the robotic arms go in. Okay, and then do the usual pre-cut, mucosal cutting. Okay, so once you finish the mucosal cutting, then you do the grasping, which is all on this side. Okay, this is all done through this thing. Can you see that? So the surgeon will actually just sit down. The scope is actually stabilized using a special way. And then after that, the left arm grafts it, stabilize it, expose it. And then the right arm, which is a cutter, similar to an ESD knife, will just slowly dissect it away. So that's where it is done. So it's good for the narrow thing, where you don't have a lot of space to manipulate. And you have you have a lot of exposure. This is on a live animal, which we did. So you just quickly, because you can see very well, and you can expose, you can pull as much as you like, so you can quickly actually cut it through and so forth. If you need injection, more injection, in fact, you don't need to. Surgeons argue that you don't need to. If you have a good exposure, you can just peel the whole thing off in one go. You're less worried about perforation. So you can just do the whole thing, and eventually, I think you can just remove the whole thing. Okay? And that's the particular thing. So I'd just like to actually finish off this talk. To essentially say that I think the future of GI surgery, I believe, resides on early diagnosis and then early treatment. So I think for early diagnosis, I think screening is a way to go. And I think the screening requires, rather than random biopsies, I think requires something which allows us to do real-time diagnosis and preferably objective diagnosis, where I think training and inter-observer variability is kept to the minimum. And as far as surgery is concerned, as we move more and more into early lesions, I think there's a place where we can actually do early surgery, so-called endoscopy, if not a combined endoscopy and surgical procedure. That's where I think a two-arm procedure has to be the way to go to overcome a lot of current limitations so that we can do a lot of complicated procedures through the internal means and then with shorter learning curve, so that I think this sort of technology can benefit as many people as possible. So I think with that, thank you very much for your attention.